On this episode of the ASC Podcast with John Goehle, we discuss the latest news, review some common survey citations, discuss some recent ASC trends, and review proper drug storage. And in our focus segment, we discuss peer review, and we will interview Carolanne Holtz, the Senior Director of Clinical Operations at Regent Surgical Health.
Welcome to the ASC Podcast with John Goehle, the longest-running podcast specifically focused on the freestanding ambulatory surgery industry. We would like to thank our sponsors, Surgical Information Systems, providing cutting-edge information solutions for surgery providers. Trivalence. Trivalence offers a comprehensive next-generation ASC solution that optimizes payment and supply chain performance, enabling actionable data insights. And Ambulatory Healthcare Strategies, the nation's leading regulatory and accreditation compliance resource for ambulatory surgery centers. For more information about our sponsors, please visit our website at ascpodcast.com.
Welcome to episode 178 of the ASC Podcast with John Goehle for December 31st, 2022, recording from Spencerport, New York. This is Sue Cronkite, Chief Researcher for the ASC Podcast with John Goehle and Senior Nurse Consultant for Ambulatory Healthcare Strategies. The ASC regulatory environment is extremely dynamic, and the material provided in this episode is based on information available as of the date of recording. Joining me is John Goehle, the owner of Ambulatory Healthcare Strategies, and recognized as one of the nation's leading experts in the ambulatory surgery industry. Mr. Goehle is the author of over 10 books on the ASC industry and a frequent industry speaker on regulatory, accreditation, and finance issues. And happy holidays to everybody. This is the last day of 2022.
That's right. We're getting everything ready for our New Year's Eve celebration here, and we thought we would get this episode recorded before then. Though we do need to point out this is take 17, I think. We are a little out of practice.
Well, John actually had COVID. It was his first time.
Yeah.
And he ended up really not terribly sick. I mean, had to rest and everything. And then my daughter, who is also staying here, ended up with it. I somehow hid out enough and separated, and I didn't get it. But
of course, you were wearing a mask all the time and stayed as far away from me in the house as possible. But,
yes.
Yeah, I mean, I had felt for a while that I might have had some natural immunity to it, and perhaps I did to a lot of the other versions of it, but this one hit me. But interestingly, Sue, and this is, we've talked with many of our clients about this issue that those centers that require a test before you have surgery, that people that have had COVID could continue to test positive for 30 to, I guess, even as much as 90 days afterwards. And I am 13 days out, and I am I've actually taken 2 different versions of the test just to be sure, and I'm totally free of it now. And I believe Amy is now too.
And well, she's going to test later today, but she's feeling a lot better. She's recovered. She's past her quarantine time. So we're trying to get back into the normal swing of things, but it kind of threw us for a loop. As well as, we're going to talk about it later, but our little Rosie decided to pick this time, the holidays, to go back into heat. So we are...
So that was our entire last week is all of the things surrounding getting her to be with puppy.
Yes.
So we're very
hoping
excited.
It took. Lots of good thoughts sent our way, please.
Please do. So we'll have a lot of great puppy pictures, of course, and perhaps we'll have some puppies for one of our boot camps coming up. So that's always a fun time. And then we had a winter storm here in western New York. It actually affected Buffalo much more than Rochester, but that's certainly, of course, we made the national news in the Buffalo area.
That was tragic.
It was.
That was awful.
Absolutely terrible. And it's been an interesting test. We have a lot of surgery centers. Ambulatory Healthcare Strategies has a lot of surgery centers in Buffalo, so they had to activate their emergency plan. Not everybody shut down early enough. Actually, the snow, usually you can prepare for a snowstorm.
But in a place like Buffalo, a lot of people say, well, we live with this. I mean, Buffalo always gets a lot of snow, but this was just so beyond what it was just terrible between the wind, which made, some areas just pile up feet and feet and feet of snow. I mean, there were like 8-10 foot drifts in some areas. Yeah. And then the really bitter cold there, it was just the perfect storm basically.
And then a lot of power outages also occurred. And quite another interesting lesson coming out of it is that while their generators were able to kick in, of course they couldn't do surgery, but their generators were able to kick in. A couple of the places, their generators ran out of fuel because the fuel company could not get there to refuel the generator. So I'm not sure there's much else that you can do about that other than to recognize that there might be a situation where you're not going to be able to keep that generator going for a long period of time.
Yeah.
We're also getting ready for our upcoming Bootcamp. The Administrators Bootcamp is going to be at the end of January here. So if you're interested in joining us, we still have some slots open. Visit our website at ascpodcast.com. While we're on the subject of the website, our patron program has become quite popular. We did introduce a brand new website. We'll link it in our show notes here for people to sign up to become a patron member. It is $25 a month. And includes a whole series of different types of benefits, including our Saturday drop-in sessions, which we talk about a lot here because we get a lot of great conversations on our Saturday sessions, as well as a lot of good advice for upcoming episodes. And now we're even getting content from some of our listeners here who help tell us about stories that we haven't necessarily heard. And we're actually going to have one in a few minutes here.
Yeah.
And lastly, as we're getting ready to introduce you to the news, this is December 31st, 2022, and this is the end of our 5th year, Sue. We started January 1st, 2018, so this is the end of our 5th year of podcasting. 178 episodes, and we're still going strong. So we have a lot of great things coming up for the next year, and of course with our patron program and the boot camps, all of these things are continuing to grow. And who would have thought that even after, we started getting back together again in person, that something like this boot camp would remain virtual and that people would still be attending it. So I think, unfortunately, for those of us that like to be getting together in person, this virtual world is the new reality. And it certainly allows a lot more people to participate in these programs, for far less than it would cost to actually attend in person.
And just makes it more doable. A lot of people, even people that try to dedicate that, full week or 4 days, depending on the boot camp, they often get called away if they've had to stay in the office to do it. But we record it so they can watch what they can and be able to ask questions and really participate, but then fill in the parts that they don't see. So it's a very handy way to do it. And I did want to mention we're hoping to record a podcast from our retreat next week. We've got that coming up with the whole crew. We got a couple that are we've got a couple people that are joining virtually, but most everybody is going to be here, and we'll see if we can get some interesting information from this.
Yep, it's a great the Ambulatory Healthcare Strategies and the ASC Podcast, the crews for those two organizations get together twice a year. Unfortunately, in 2022, we were only able to get together once a year because of various problems, but hoping to get back to our regular schedule. And during these retreats, and we talk about the importance of getting a retreat for any organization, surgery centers, for our company, et cetera, gives you an opportunity to kind of sit back and reflect on your business model. In our case, that's when we decide upon changes to our quality improvement programs or our governing body minutes or our policy manual or our educational programs. And all of those things are items that we'll be talking about in this upcoming event. So as well as new services that we'll be offering. We have a lot of great new things going on in Ambulatory Healthcare Strategies, including a new relationship with a partner that will help with our electronic or our web presence. So a lot of stuff going on. So keep a very close eye on what's going on with us. So we have not been together for about 3 weeks. So let's update everybody on the news, Sue.
Okay. I wanted to talk a little bit about some recent citations just to keep everybody aware of what everyone's looking for out there. I saw this part on the Ohio State Association's website. Recently, Kara Newberry, who is the Director of Government Affairs and Regulatory Counsel for ASCA, reported on the top citations from CMS in 2022. The highest number, which at 11%, was for sanitary environment. This is a lower percentage than in 2021, where it was 17%.
That's kind of concerning to me. That sanitary, of course, means the cleanliness of the organization. Yeah. And, Sue, in my recent site visits, I guess I have to agree that this is something that I've been seeing recently with surveys that I've been doing and mock surveys. And I'm not quite sure, I think coming out of COVID, people would be a lot more careful about it. But I suspect this has a lot to do with our staffing problems. And
probably other things have kind of taken over some of the issues. The second highest was administration of drugs, and that was at 10%. And a new tag this year was Q0246, which is COVID-19 vaccination of facility staff, but that actually only made up 3% of the citations.
Meaning that most people are making sure that their staff has been fully vaccinated.
Yeah.
It's interesting, that second highest citation regarding administration of drugs. I wonder, we'd have to delve into that a little deeper, but I can just speak from experience with our own, with my own mock surveys and real surveys, is that tends to be the labeling of the drugs, using the drugs that have been drawn up, within an hour, or making sure that multi-dose vials are drawn up in a non-patient care area. That in particular has been an area. So a lot of those things, and you might want to refer back to, if this is new to you, refer back to our episode. I think it was just the last episode on pharmacy.
Yes, and I think we should be able to get a lot more information on this as more of it comes out, because this is just kind of a very brief overview. And one of the survey organizations, ACHC, also sent out some information on their most frequent citations. And they gave some examples. So 45% of the centers had deficiencies in medical records, and some examples were handwritten documentation was illegible. Imagine that from a doctor. I can't imagine.
And the rule that we have as surveyors is that somebody in your organization has to be able to read it. And if nobody can read it, then it's considered illegible. And just the survey that I did most recently, there definitely was a problem with legibility there. And again, the staff could not even read what the doctor had written.
That's a problem. Automated timing and computerized system is incorrect. So
that's an interesting
I believe probably, it was auto-populated. And we see this as well with, orders and things like that. If you have an auto-populated thing, you have to go in and make it specific to the patient, make sure it's actually accurate.
Yeah, and Sue, that brings up another point that you reminded me a while ago, is that when I think you had listened to a attorney talking about electronic medical records, and that one of the banes of his existence was the fact that they, that when they were defending surgery centers, that often the auto-population would be causing the problems in those electronic medical records, because there would be wrong information, or information was clearly wrong, but because of the auto-population, it was automatically there.
Yeah. And transfers were missing information, such as the reason for the transfer, the order for the transfer, and the doctor's progress notes. And 29% of the centers were cited for administration regarding personnel records, and those included lack of employee files for the per diem staff.
Oh, wow, that's interesting.
Missing content such as a nursing license or evidence of annual training and orientation, which is not that surprising to me, that orientation, people don't always document that as appropriately as they should.
And Sue, I've seen recently in some of our site visits that surgery centers that are using agency staff forget that they have to have an employee file for that individual also.
And orientation. And they think, well, we don't have time. They only come for a day, but you have to do it.
Yeah. And think about that again. I think we've talked about it, but I got to emphasize this, is just think about, the danger that you could have if that agency staff person encountered a problem. If they're a nurse that had an emergency, do they know even where the crash card is or what's in the crash card?
And 29% was medical staff granting privileges. Files were missing the written letter of appointment, including beginning and end date of appointment.
Which I've seen quite a bit too. Yeah.
Governing board minutes have no documentation of the board granting privileges to physicians. So the paperwork's done, but nobody ever,
Which I've seen, again, just recently during survey and during mock surveys. So, this is very consistent with my own experience.
So the next one is 32% medical staff credentialing files. So this is specifically the credentialing files as opposed to the process of granting privileges.
Right.
No evidence of MPDB queries or dated appointment or reappointment letters with date of expiration for credentials. The files were not consistent with medical staff bylaws, and no primary source verification for CRNAs. And I know these last two bullets were things that you had wanted to discuss, John.
Yeah, I've seen a lot of problems recently with people not having updated medical staff bylaws. And frequently what happens is the staff hasn't even read the medical staff bylaws. And in some cases, these bylaws are very, very old. I had a recent situation during a survey where the medical staff bylaws were from 10 years ago when they started the organization. And it listed a whole series of committees that this organization was supposed to have. And there was no evidence that these committees ever existed. And what's even worse is that those committees were assigned responsibilities that were not evident anywhere in the organization.
Yeah.
So they had no proof that those functions were being done. So read your medical staff bylaws. The other thing that happened with that is that they were not following the medical staff bylaws with regard to initial appointments, which had a different time frame than ongoing appointments. So it was less than the 2 years.
Okay.
And every one of their files, there wasn't a single file that was in compliance with their own medical staff bylaws, which does not look good in a survey because it's 100% failure.
Same thing as like with the policy manual. You might be doing what you might look around and say, well, this is the correct way to do it, or a lot of centers are doing this way, but you've essentially made your own regulations when you've done your bylaws. So you have to meet not only the law and the regulations, but you have to follow your own rules. So if you're not, then you have to change them change what you're doing. And the primary source verification for CRNAs.
We've talked about that a lot. The NBCRNA website does provide primary source verification. And I am curious here, not saying that ACHC doesn't have surveyors that know this, but it is confusing. I found some inconsistency with regard to surveyors who are not aware of NBCRNA's process. So as I've noted before, when you're printing the verification of the CRNA's education and training, print both the actual verification and the page before you verify them.
That says that it is primary source. And again, we don't know if this is it. There are also, I'm sure, are a lot of centers that maybe just aren't aware that they have to get primary source verification for CRNAs, or just haven't done it. But this just kind of triggered that in our minds because we've run into that a lot of times. And
again, I sense that this might be more of an issue with regard to surveyors. And if your surveyor does say, hey, wait a minute, NBCRNA does not provide evidence of primary source verification, well, what I would do is I would take them online, show the surveyor online how it does indeed provide primary source verification. But you can avoid that whole situation if you actually print the page from the NBCRNA website that says that they do the primary source verification of education and training.
And then I saw some top trends in surgery that was reported in the December 2022 Outpatient Surgery magazine. Now, there were a few.
It's a good thing to talk about during the last episode of the year as we go into the new year.
Here's what's been happening. But they had more than what I'm talking about here, and they really delved into why it was happening, what you can do to combat it. So it's a really good article, but I'm just going to briefly mention it. Recruitment and retention issues. No surprise there at all. It's, and they did make the point that it's not just nurses, it's techs, it's, just
even
everybody.
I think upfront staff, administrative staff are finding problems with billing and coding and
everything.
Cleaning staff. It's across the board.
And an increase in ASC-based cardiology.
As those new procedures are being approved for Medicare patients.
And a much lower cost. I think they said it's usually 30 to 40% of what a hospital would charge. Yeah. Decrease in physician-owned ASCs as more management companies are taking over a higher percentage of ownership. So they, maybe a physician owns 49% and then they own 51%. So that's a big change.
Well, in deference to all of our listeners who are with management companies, this is kind of a sad trend for me. I mean, most of our clients at Ambulatory Healthcare Strategies, of course, don't have a management company, or we work for the management company. But I like to see those independent centers, and I like to see those continuing. So it'll be interesting to see what happens here. This is one of those trends that tends to not. I think we've seen this in the past, and then it drops off. So we'll see if this is something that continues.
Yeah, and this was interesting. Off-site sterile processing departments to save space in the center. So, when you're needing to expand and you need another OR, I guess some sites are doing third-party processing or doing it, at a remote location.
Yeah, and I haven't seen that. I've heard of it, but we don't have any clients that do that at this point.
Yeah. And cybersecurity threats, such as ransomware attacks, of course, are getting...
Please, if you haven't listened to our episodes on this or the many webinars that the cybersecurity organizations have done, definitely take this seriously, because it has affected a number of our clients in the past year, and many of them just really have not had the infrastructure in place in order to be able to avoid this type of a situation.
And interventional radiology, sometimes called pinhole surgeries. They are therapeutic procedures that were traditionally open procedures or laparoscopic. They're less invasive, less painful, and may only need sedation instead of general anesthesia. Many of these procedures are in that cardiovascular realm, such as breaking up clots, placing stents, or filters.
That's interesting. So a lot of interesting trends going on in the industry as we go into 2023.
And I think lastly, this recently came up in a mock survey for John. There was a center that was storing their controlled substances in a rolling cart. So somebody could just roll it on out the door.
Yeah. I asked you to, in a few minutes, you're going to talk about this, because I knew it wasn't right. And especially since the control, so they were storing all of their drugs on these carts. They actually had a couple of them, but one of the carts had installed on it a double lock cabinet for the controlled substances. And I'm just very uncomfortable with that, because just as you said, Sue, you could just roll that thing right out the door and
figure out a way to get into it.
Take your own sweet time to open up the box. And it definitely did not seem to be right. So you found some guidelines, the general guidelines, though, right?
Yep. So the general guidelines are all controlled substances must be stored in a double locked container. If you're using keys, you should store the keys in a separate location from the cabinet, of course. We have seen cases where they're hanging right next to it.
Or both sets of keys.
There you go. Yep. Makes it easy, but we don't want it to be easy. And actually separate from each other, the two keys.
Yeah.
If you're using combination locks, only share the combination with as few responsible individuals as possible, and change the combination, of course, whenever a staff who had access is no longer at the center. And in addition, for Schedule 1 and 2 substances, they must be kept in a safe or a steel cabinet that is either over 750 pounds, so, difficult to move, or mounted securely to something such as a wall or a floor, or embedded in cement. So basically it has to be very difficult to move.
Right. Which this rolling cabinet did not. It was clearly not that heavy. And again, we're talking about
once you put wheels on it, you want it to be very hard to pick up and move, or be attached to something immovable, basically. For Schedule 3, 4, and 5 controlled substances, they should be stored using one of the following methods: either a wall-mounted controlled substance lockbox with 2 doors and 2 locks, each lock having a different key. Lockbox stored, and that's really the most common one. A lockbox stored in a non-public area in a locked room, or a secure, substantially built locked drawer. So basically it's double locked. Schedule 3, 4, and 5 substances can also be stored with the Schedule 1 and 2 substances. And for cold storage for controlled substances, for storage at 4 degrees Celsius or colder, a single lockbox in a refrigerator or freezer that can also be locked is permitted. The room must also be lockable and be locked after hours. And I just want to remind you, these are general guidelines, so please check with your pharmacy consultant if you have specific questions and to get more information.
And so this is all well and good, and you've provided great information, but I walk into places who have all of these systems, and then they leave the cabinets unlocked.
Yes.
The famous example is anesthesia carts. Great. I mean, they've got all of the proper locking mechanisms there. They just leave them unlocked when somebody is not in the room. And so our systems are only as good as how well you actually follow your policies and the requirements there. So it's good to look at these things. But I think as much as these become issues, like these rolling carts are an issue, more frequently we find that they have the proper equipment, they have the proper setup, and they're just not locking things up afterwards. And we have to remind you during this time is when we're seeing an increase in the amount of drug diversions, that we have to take this seriously. Yeah,
and I think also at this time with lower staffing, people sometimes just kind of try to take the easier way out, and they just... they don't want to look for the key. They want to have to go get it. They just want to make it convenient, but you can't do that.
Well, and we've seen people say, well, I know my staff. I've known these people for a long time. They wouldn't do that. I'll tell you, every single one of the diversions that we've seen recently have been among people that know each other and, they're trusted employees. So
yeah, you can't tell an addict just by looking at them
right.
Or somebody that's depressed or, it's... And you want to protect them as well as your center.
So one of the issues that's been coming up recently on surveys as well as on our Saturday drop-in sessions for our patron members is the issue of peer review. And surveyors are getting a lot tougher about peer review. It is one of those areas that tends to be very difficult to get compliance from the doctors, because the doctors, especially if they come to a surgery center, they just really don't want to do anything but do the surgery. And of course, doing peer review takes time away from their paying job. But we have to take this seriously, and we thought that we would do a focus segment on it. So let's take a break, and when we come back, we'll talk about peer review. It's been a long day, and the surveyor's just left, and you are exhausted. And looking at the list of items that you have to address, you wonder, how can I deal with this and still take care of my patients? More importantly, you wonder, how can I ever keep up with all of the regulations, standards, and accreditation requirements? How can I always be prepared for a survey and reduce my stress levels? Well, that's what Ambulatory Healthcare Strategies does, day in, day out. We become your outsourced regulatory and accreditation resource. We can maintain your policy manual, develop your education programs, help out with fire and disaster drills, do your risk assessments, oversee your quality improvement activities, help run your quality improvement meetings and governing body meetings, and we can even prepare your monthly or quarterly financial statements and help you figure out where you are financially. We are a retainer-based service. We don't take ownership. We don't charge based on your revenue. We have one fixed monthly fee, and we can tailor your services to your exact needs. So whether you're looking for help getting over a survey, preparing for a survey, or looking for a long-term relationship to assist you with your ongoing regulatory and/or financial needs, please give us a call at 585-594-1167 or email us at info@ahstrategies.com. That is info@ah-strategies.com, or visit our website at ah-strategies.com. So let's talk about peer review. So as we always like to do in our focus segment is we want to go right back to the CMS Conditions for coverage, the Medicare regulations for ambulatory surgery centers. And the one that is applicable or most applicable for peer review is 416.45b, which is the condition for coverage, the standard for reappraisals. Medical staff privileges must be periodically reappraised by the ambulatory surgery center, and the scope of procedures performed in the ASC must be periodically reviewed and amended as appropriate. So interestingly, the interpretive guidelines don't actually specifically state that peer review has to be done, but as we read through them, you'll see that there definitely is the implication that you have to do this. Sue, why don't you read the section from the interpretive guidelines?
The ASC's governing body must have a process reappraising the medical staff privileges granted to each practitioner. CMS recommends a reappraisal at least every 24 months. The reappraisal must include review of the practitioner's current credentials, and the practitioner's ASC-specific case record, including measures employed in the ASC's quality assurance performance improvement programs, such as emergency transfers to hospitals, post-surgical infection rates, and other surgical complications. The ASC's governing body should use a similar process, including the recommendation of qualified medical personnel for the periodic reappraisal as it is used when initially granting privileges.
So whereas this doesn't actually state that we're doing peer review, of course, peer review is what is mentioned here, is what they're talking about here. The practitioner's ASC-specific case record. And the other thing that I find interesting as I'm reading this again is that does really make it extremely important to understand the interrelationship between the QAPI program and your peer review when it talks about, the review of the emergency transfers, post-surgical infection rates, et cetera. It was interesting. When I did a recent survey, the transfers were actually not, there was no incident report for them. They had a log of the transfers, but there was no incident report, which made it very difficult to determine that the organization learned anything, from that event. And of course, that's an absolute requirement, especially since those all involve an actual adverse event. So they were in quite a bit of trouble, unfortunately, because of missing that particular element in their transfers. But what this is indicating in 416.45b is the importance of reviewing all that information, having like physicians, people that are peers to them, looking at each of these complications in order to determine if there's anything that has to be looked at further and whether you should be granting privileges to those individuals. And then it does point out again the importance of the governing body being involved in this process. And so many times I'll go in and the governing body minutes will have no indication at all that that peer review is being done. There might be peer review records in the organization, but the governing body has to be reviewing that peer review, and it somehow has got to be documented in the peer review minutes. So the ASC governing body should use a similar process, including the recommendation of qualified medical personnel. Again, implying peer review here for the periodic reappraisal is used when initially granting privileges. So a question that sometimes comes up when people ask me this question, do I need to have peer references if I'm doing peer review? Now, that really depends upon your accreditation organization. So be aware of your accreditation requirements. I can tell you, for example, the AAHC does not require you to have peer references on reappraisals, assuming that you have peer review being done. Another question that comes up periodically is, what do I do if that practitioner is up for reappraisal but hasn't done any cases? So that would be a situation where you obviously don't have any peer review, and you'd have to go back out and get peer references. So upon reappraisal, you're going to have to at least get peer review done or peer references if no peer review could have been done. Now, the Interpretive Guidelines goes on to state that the ASC must also reappraise a practitioner at any time the practitioner seeks to perform procedures outside the scope of previously granted procedures, and the ASC should also develop triggers for reappraisal of privileges outside the periodic reappraisal schedule, meaning that anytime they want to get additional privileges, you're going to have to look at their ability to do that and any recent experiences that you've had with them, as well as, keeping track of things that have been happening. Have they had an increase in perforations in a GI situation, an increase in the number of unplanned vitrectomies to a point that it's above the norm? All of those things would be triggers for reappraisal. In other words, doing advanced peer review. And it's also important to note that there is a presumption that you're going to be doing peer review on any of those cases that didn't go as they were planned. I really want to point out and make it very clear here that peer review is not just random chart audits. So many times people assume that the only thing required for peer review is random chart audits, and that's not the case at all. So peer review includes random chart audits, and enough to be significant. But it also includes a review of cases that didn't go as planned, like adverse events, transfers to the hospitals. You're also going to want to be looking at complaints and grievances. You want to look at the tracking and trending of incidents and other activities. Is this infection rate going up? That might, require you to do peer review of that doctor's infection practices. And it might also include things like the way the provider interacts with patients and staff and their ability to complete charts on time. Lastly, I do want to point out that we really assess whether healthcare professionals have been involved in the development of the criteria that you're using for peer review. In other words, those chart audits or the focused audits, those items that they check off, they should be something that the peers that these professionals have done, not something that you got from consultants like us. So we'll give you some recommendations and perhaps a list of different things that need to be looked at or should be looked at. But really the peers have to be looking at that list and checking which ones are applicable in their circumstances. Now, during the Massachusetts State Association meeting a couple months ago, I had an opportunity to interview Carolanne Holtz, the Senior Director of Clinical Operations at Regent Surgical Health. Now, I had an opportunity to actually listen to her speech, and she was incredible. She did a great job, and it's one of those topics that you don't really see included in a lot of conferences. So I had an opportunity to interview her, and let's listen to that interview now from the Massachusetts State Association meeting a couple months ago. So this is John Goehle. I'm here at the Massachusetts State Association meeting in, October of 2022?
Still October, yes.
It is still October in Waltham, and this is a great conference, and this is the first time the Massachusetts Association got back together after the pandemic, and I'm here with Carolanne Holtz. Now, I had to get that last name down, and Carolanne, you just did a fantastic presentation on credentialing and peer review. One of my favorite topics, one of those areas that we talk about a lot on the podcast.
Mine too.
But one thing we don't talk about a lot is peer review. So let's kind of focus on that in our discussion today, because it is certainly you're a surveyor also.
Yes.
With HHHC too, right?
Yes.
So we both know that this is an area that's becoming much more of a focus now, especially in the last, I'd say probably 3 to 4 years. And I don't know about you, but it's one area that I find when I'm doing surveys is almost always either deficient or not quite where we all want to be. So
it's not robust usually. It's not comprehensive. It's usually just like a chore to get through. Did we get the numbers right? Did we get the amount that we need to do? But there's very little attention paid to the quality of what's being reviewed, and also the I would say just the consideration, like for the benchmarking, or how do you apply this data other than reappointing providers, because it provides so much more value than just that.
Well, and I think there's a perception that peer review is simply chart audits. And you made it very clear that there's so much more to it. And as I'm listening to you, I'm also thinking, we really need to spend a little bit more time talking about there were a couple questions from the audience about what's reportable in MPDB. So this is a lot to chew off, and you got to catch a plane. We could be probably talking for hours.
That's okay.
But let's just focus on, first of all, let's speak for a minute about what is the biggest deficiencies we find in peer review programs, and what can our centers do to enhance that?
Yeah, I would say, the biggest ones that come to mind is maybe that they don't incorporate any documentation to support the use of the peer review to support their reappointment periods, reappraisals for providers. So that's a big deficiency I often see.
In other words, actually getting that documentation to help support the re-credentialing at the board level.
Right. Actually aggregating the information and analyzing it and doing something with it to say, okay, yes, we have looked at everything and we are putting this person forth for reappointment. I think that's a huge issue. And I think from an accreditation standpoint, that's huge. I think sometimes the part about the adequate, providers who are doing the actual peer review, or that they actually have, special criteria that they've been a part of creating, that's also a big thing. I think sometimes there's a misunderstanding about what's required. So,
for example, you don't want to, did the surgeon sign off on the operative, notes or the orders? That's something a nurse can do. Why waste the doctor's time for doing it?
The nurses can do a content review, but we need to have the providers really doing the appropriateness of care, patient selection, et cetera. All of those areas that they should have expertise on, which is why it's important. Ideally, you want to have those appropriate specialties reviewing one another when you can. I think it's an important part to examine at your center is, do we have the right people reviewing these cases? And I have centers I've seen where they have an anesthesiologist who reviews all of the medical, charts.
Right.
I don't know if that's really appropriate, and I think they need to be looking at that. And so looking at the appropriateness of the review process, who's doing it, what they're looking at, and the criteria.
And how robust it is.
And how robust it is. I mean, if you have all of this data and you are not using it for the value that it provides, you're missing out on a great opportunity for a quality improvement.
Yeah.
I think you have to, that's part of your tying it into your quality improvement program. That's what you need to be doing. And it's only by using those, performance criteria that you are looking at, you've established here are criteria, here are thresholds. Now we're going to look at each provider and where they fall into those categories. And like you showed you in the slide, sort of who falls out, who are the outliers, and is it a provider problem or is it systemic? I mean, I think if you don't really look at those very closely, you're missing out on a huge opportunity. And also for the point of talking about, they want to suspend providers or terminate providers. If you're not giving them the opportunity to improve, you are not doing due diligence. You're not really making the effort that you should be making for these providers, because they also have rights. They also have rights to fair processes. Just because you see that maybe they're subpar in some areas, you have to address it early as you can and give them the opportunity to improve and work with the medical director, work with their peers. It's really important.
There was a great question from the audience about newer providers, in other words, younger people, because we're starting to see that.
Yes.
It used to be that the only people that come for a surgery center is somebody that's already done 1,000 of these procedures.
Yes.
But we know now that those opportunities, those doctors are few and far between. That now we're going to most likely see, as people are retiring, younger people coming up through the ranks. And to your point, that's exactly it, is that you don't want to discourage, you don't want to just brush somebody off who could probably learn from an event that occurred or for something that was not done, rather than just getting rid of them.
Right. And what an opportunity for these young guys, or these young providers, I should say, because we need to start looking at the future of ASCs. We need to start looking at these young providers and giving them a place to do their cases. And part of that is going to be, how do we incorporate this into what our current, processes look like and our current policies? If we don't make accommodation, then ultimately, the center's going to die with the physicians as they leave. So we have to accommodate that, but we have to see, how is that appropriate? How can we fit this in? And be somewhat open-minded and transparent with your medical staff about this is what we're looking at we have to do for growth, and we need to pull in these, the people from your medical exec committee, et cetera, and look at how do we accommodate this? How do we provide the right field to give these physicians a chance to spread their wings and to grow within the surgery center? So it's really important to do that. And I think it's also important to, aside from the processes that you have to maybe look at within your center, you have to determine what percentage of your providers on your medical staff are going to be new, because there's also going to be that offset of if they're not as efficient.
So let me ask you a question, and I'm sure you run into this a lot. We'll go into a center as a surveyor, and the peer review is, 150 charts reviewed for the year, 100% compliance.
Yeah.
What is your immediate thought when you see that? Because I bet a lot of our listeners are in that boat.
Yes.
And it's not because, remember, our listeners are the administrators and nurse managers.
Yes.
For the most part. We have some medical directors.
Yeah.
But, so we don't have control over what those numbers are.
Right.
But we've got to kind of tell them that that's probably not acceptable anymore. What are your thoughts on that?
Well, I mean, with all due respect to their processes, hey, they might have really good review. If it's 100%, I would say, if that's truly what you're getting back, then maybe go back to the drawing board and look at the criteria that you're looking at.
Lower the bar. Yeah.
Well, yeah, I mean,
not lower the quality, but lower the bar so that you're looking at more things that you might not have been looking at before.
Look at the criteria. Look at more things. Maybe change it up. Maybe add some things. Like I said, talk to the providers who are performing these procedures and say, what criteria can we add that we're not looking at? I think that you're doing yourself an injustice at the surgery center level if you're not doing a good job with the peer review. So anytime you have something that's 100%, you have to look at it from the perspective of, are we digging in enough? Are we is this robust enough to basically support the quality improvement initiative? Because if it's not, then you could have the 100% till the cows come home, but then all of a sudden you're surprised by something that happens, or there's an issue that comes up and it's completely lost in the noise. I mean, like I said, if you're not including compliance, if you're not including patient satisfaction, you're not including...
In addition to these chart audits,
in addition to all of the chart audits, I mean, you have to incorporate these other things. So, are they subpar? Or is the clinical observation that supports their competence? Yeah. If those things are not all tied into it, or their behavior, like I said, their conduct, professional conduct, I mean, we're missing out on some really good stuff here, because part of that is our responsibility to ensure that we're looking at quality improvement possibilities, and that we are, I think even just for the sake of holding them accountable as professionals, because without professional accountability, like I said, like I mentioned earlier in the talk about these bullies and whatever, we let people get away with things for an extended period of time without addressing them. How are we serving our patients that way? How are we serving our staff that way? If I was a nurse still at a surgery center and I had a physician who was a constant threat to me as a bully or whatever, I would probably consider leaving, because my work environment stinks. You know, I mean, this is part of what we need to consider. It's part of making the environment a safe culture of reporting and feeling good about what we're doing to take care of our patients. And that really won't happen when you have, somebody who's creating a toxic environment.
So, staying on the topic of what other things should we be looking at, it strikes me that some of the initiatives that we worry about operationally as an administrator, director of nursing, like on-time starts, like timeouts, like the infection rates, those are things that we should be including as part of peer review, can help us out and are no doubt not going to be 100%.
Absolutely.
And so those are things you should be integrating into your peer review program, tracking the statistics there, sharing them with the board, and then letting the medical director, you mentioned this too, that, it's not our responsibility as DON or administrator, it's really the medical director who has to kind of fall onto this bandwagon or jump onto this bandwagon and start working on it. So your thoughts, that you had a great slide on that, and just talk a little bit about how you can integrate that into a good, robust peer review program.
So John, you're referring to the performance dashboard that we were looking at, and I think that's a great way to, as we said, aligning your peer review activities with your quality improvement program, is you're looking at these performance indicators or your KPIs, whatever you want to call them, quality measures. You want to be able to line them up and really focus on each provider. What is their, what's their rate on each of those areas? You're looking at their surgical site infections. You're looking at maybe their hospital transfers, and other quality measures that you would put in there, burns, if their patients have DVTs, whatever you're putting in there. But then you want to also incorporate, like I said, patient satisfaction. What are the comments that they're getting from patients from their experience? If you're getting comments about issues with communication, issues with wait times, just general problems around scheduling, communication, et cetera, those should be incorporated in as well, because it's all about the patient experience. We're doing all of this because we want patients to have a high quality experience, a safe experience, and when we have these outliers, it's our duty to actually, look at what are the thresholds here. If this person is not meeting the threshold as a provider, we need to address it. We need to look at it sooner than later. Yeah, it's important to be able to look at these individual measures and benchmark them against each other. Because the other thing is, I mentioned during the talk, you can't go to your executive committee, your medical director, your governing board, and just say, this provider is not doing a great job. You need to quantify everything. You need to be able to show what is their performance compared to their peers. And it's only when you have that in black and white in front of them that you have something substantive to be able to support that.
Absolutely.
Yeah.
This has been great. I so much appreciate your time. We were talking before we turned the microphone on here that we really probably need to do a full conference on something like this, because I think peer review, you got a lot of great questions. I mean, that
got
itself,
great questions.
Should be an indicator that this is something the audience wants to hear
Oh,
from.
it's so important. I mean, if we haven't learned anything, even from like Dr. Death and stuff like that, I mean, credentialing and peer review it's a lifeline. It's a lifeline to the safety and high quality care that we're providing our patients. And we can't take it lightly.
Right. Thank you so much, Carolanne.
You're
I know
welcome.
You got to catch your plane flight.
You're welcome, John. Thank you so much. I appreciate it.
In this segment, we provide an update on upcoming topics for the podcast, our upcoming virtual conferences, and upcoming speaking engagements for John and his staff, and other events in the ASC industry.
And our ASC Administrators Bootcamp for administrators, ambulatory surgery centers, and those looking to become CAS certified will be January 24th through the 27th, 2023. For more information about that and all the benefits of joining on our bootcamp, visit ascpodcast.com.
And ASCA's 2023 Winter Seminar is January 12th through the 14th at Caesars Palace in Las Vegas, Nevada.
And I'll be heading out there to do a whole morning on finance and accounting. There's kind of like a mini boot camp, I would say, for finance and accounting at that conference. So for more information on ASCA 2023's Winter Seminar, visit ascassociation.org.
AORN's Global Surgical Conference and Expo 2023 is April 1st through the 4th at the Henry B. Gonzalez Convention Center in San Antonio, Texas.
And ASCA 2023 Conference and Expo is May 17th through the 20th, 2023 at the Kentucky International Convention Center in Louisville, Kentucky. And I'll be doing, I think, 3 speeches there, and Lori will be down there also with us, as well as quite a number of staff from the Ambulatory Healthcare Strategies group. So definitely visit ascassociation.org to sign up for ASCA 2023. And also don't forget about our recorded events. They're all available on ascpodcast.com. We have a credentialing conference that we recorded in 2020. It was a full-day conference talking about how to do credentialing, provider credentialing in an ambulatory surgery center. And then in fall of 2022, we did a finance, accounting, and reimbursement conference, which is now available. We also did a conditions for coverage conference. The recording's available we recorded that in 2021. It's a really good conference, Sue, right, for explaining all of the conditions for coverage. We're going to have to re-record that soon. And then also in 2021, we did a medical director conference, which talked to medical directors about the responsibilities that they have, particularly during a survey and what their responsibilities are as a medical director. And don't forget about our on-demand version of our Director of Nursing and Administrators boot camps. Those are newly revised, and they're available on our website at ascpodcast.com. And again, let's remind everyone to become a patron member of the podcast. Patron members help support our efforts here in maintaining this free podcast. And for $25 a month, you get a whole host of benefits. The patron program is also known as ASC Central. As we indicated, there is a brand new website for it. And it's an exclusive membership website that provides a one-stop ASC regulatory and accreditation compliance operations and financial management resource for busy administrators, nurse managers, and business office managers. The resources that are available include virtual conferences, links to various resources, policies and procedures, forms, drills, and other information, as well as access to free AEU credits just for listening to the podcast. And probably the most important part and the benefit that everybody seems to enjoy is those Saturday drop-in sessions where you can meet via a private Zoom link with other patron members and talk about things that are going on. We usually talk at least an hour, sometimes an hour and a half every Saturday morning. It's not every single Saturday, but it certainly has been for at least the last couple months. And membership does help defray the cost of producing the podcast, including our research staff, travel costs to conferences, equipment costs, and the production cost. And for more information, of course, you can visit ascpodcast.com. And that's it for this episode of the ASC Podcast with John Goehle. And please spread the word about our podcast with your friends and colleagues, and do us the honor of hitting the subscribe button. The sound editor for this episode is Susan Cronkite. Executive producer is John Goehle. Research assistance is provided by Susan Cronkite, Jenna Alvarez, Judy D'Ambrosio, Alex Borneman, Zach Caloritis, Amy Durbano, Lori Rodricks, Kathy Foti, Donna Macchio, and Ann Geyer. Music is provided by Media Sushi and Mike Noah. And the ASC Podcast with John Goehle is hosted on Podbean and is available on all major podcast channels.
This episode of the ASC Podcast with John Goehle is sponsored by Surgical Information Systems, Trivalence, and Ambulatory Healthcare Strategies. Surgical Information Systems provides cutting-edge information solutions for surgery providers. Trivalence offers a comprehensive next-generation ASC solution that optimizes payment and supply chain performance, enabling actionable insights. Ambulatory Healthcare Strategies is the nation's leading regulatory and accreditation compliance resource for ambulatory surgery centers. For more information about our sponsors, visit our website at ascpodcast.com. This podcast is an educational and operational tool and is not intended to be a comprehensive resource for all rules, regulations, and standards that an ambulatory surgery center must meet. The advice provided should not be considered as, nor does it constitute, legal advice or opinion. When reviewing specific situations involving legal and regulatory issues, attorneys and other professionals should be consulted. This has been a production of Eden Group Development. All rights are reserved. If you are interested in advertising or sponsoring the ASC Podcast with John Goehle, please email us at info@ascpodcast.com. We would love to hear your questions and comments. Please email us at comments@ascpodcast.com.